Hi, everyone, and good morning, Rachel and Vilma. So I'm excited to help moderate this very interesting and special session for this. We are going to be discussing menopause and its influence on healthy aging. We know menopause has existed since the beginning of human history, but it's only recently become quite a hot topic and a specialized field in its own right in both medicine and science. So this morning we're going to explore with two special guests. We've got Dr. Rachel Hines, a GP specializing in women's health and the menopause, and Vilma Oliveira, a senior researcher in menopause and aging. And we'll try to get through some of the key research areas and how specialization, both in practice and science, can improve societal health and longevity for individuals. So I don't want to linger because I know we have a lot to talk about in a relatively short span of time. So if I could go to my guests for some quick self-introductions, and I'll start with you, Rachel, just because you're the first on my screen. If you could go through and introduce yourself, your background and your experience.
Thank you for inviting me today. I'm a general practitioner, so a GP, and I've always focused on women's health. So I've got diplomas in obstetrics and gynecology and sexual and reproductive health care. When I was working in community gynecology for a few years alongside my GP job and developed a real interest in menopause, and then completed my advanced menopause training. So I'm now a British Menopause Society menopause specialist, and I work in an obstetrics and gynecology practice where I work as a menopause specialist, and sort of provide holistic care for menopause. I'm sort of particularly interested in premenstrual syndrome and migraines around menopause, but see women with all aspects of menopause care, and also focus on contraception and women's health as well. And I've got lots of experience working in digital health in menopause as well, so working on a wider scale of bringing menopause to everyone, hopefully.
Thank you so much. And Vilma, can we come over to you for a quick introduction?
Yes, sure. Thank you. Good morning, everyone. And thank you for the invitation to be here. It's my pleasure to talk about this subject that I really love to do my research on. My name is Vilma, and I'm a senior researcher in the field of aging. I had a degree in biochemistry since 2002 and a PhD in cell biology. I work at assistant investigator at Multidisciplinary Institute of Aging. And my research explore how estrogens, the female hormone, regulate the cellular metabolism and how the hormonal shift during a menopause can lead to menopause-related health conditions. You are muted.
Now I'm on mute. Sorry, it's a little early here in the UK.
Yeah.
So I'll go to you, Rachel, first with an early question. Menopause has become an evolving specialty, and maybe you could talk us through what factors have contributed to its increased focus, and how do you see that increased attention influencing healthier aging in society?
So I think it's been such an interesting time. We've got more and more women in the workplace, and women are living for longer. And so now 50% of women will live their life in a postmenopausal state. By 2025, more than 1 billion women will be peri or postmenopausal worldwide, which is obviously a huge number. And the average age of menopause worldwide is 48.8, which is quite specific, but it reflects how much of our time is still spent in a very productive way, which is a change to previous. The average age for death in the UK is 82.8. Obviously, it does vary worldwide, but it's a huge amount of time. And I think for many years, following the Women's Health Initiative study in 2002, prior to that, menopause hormone therapy, or HRT, was prescribed, and the findings of that initially scared women significantly, and the focus really shifted away from menopause. I think it was thought it was going to give you breast cancer, it would give you heart disease, and the focus from menopause just dropped. And as a GP, women weren't presenting with menopausal symptoms. It just didn't become, women weren't seeking help that they needed. And then in the last few years, or certainly in the UK, the NICE guidelines came out in 2015, and increasing evidence showing actually that HRT is safe to take for many women, not everyone, but most. And I think it's really shifted the focus on how we can manage menopause. And in the last few years, certainly in the UK, that it's become so present in the media. So it's sort of celebrities and influencers, journalists, there have been documentaries, but it's really brought it to the forefront of attention. And therefore it's really changed, I think, how menopause is seen in a positive light. And it's not something that's embarrassing to talk about. And certainly as a GP, the change was profound, from prescribing HRT occasionally to it being half my clinic. So it's been a really big shift when I was working doing that. And I think the increased attention is really positive. Women are presenting saying, I'm having these symptoms, what can I do about it? And in terms, therefore, it's leading them to kind of implement lifestyle changes, prioritize their health. And that links into having healthier aging so they can get advice, make, exercise, dietary changes, everything, which will then lead to healthier aging. So it's a hugely important and, from my perspective, really exciting time, because it really does feel that change is going to happen and is happening already.
Brilliant, thank you. And Vilma, as a senior researcher in the field of aging, could you shed some light on some of the latest research regarding menopause and how it affects women's healthy aging? And how does our research in this area help bridge our gaps in understanding on the long-term impact for women's overall health?
After menopause, there is a shift in hormonal, the hormones in women change, and that affects all women health, not just, we don't get just the symptoms, that the normal symptoms that most of the women talk about, like hot flushes and all of those migraines and all of those symptoms, but it also really affects the health of the body. For example, there is an increase the bone resorption, so an increase in osteoporosis, a risk for your osteoporosis and bone fractures. It's also interesting that women after menopause, they are more sensitive to heart problems and heart attacks too. So now it's not easy to work with hormones doing basic research that I'm doing, because in human body we have a mixture of the hormones changing and different concentration of the hormones. But so we try to, for example, explore the effect of the estrogen in certain organs and certain cells, and explore those kind of the mechanisms to understand how the cells behave in the presence and absence of the estrogen and doing different hormones, and play a little bit with different concentration of those hormones, try to find in vitro the mechanism that we can find a way that, okay, this mechanism could be addressed, and maybe in vivo we could improve the symptoms. So further in vitro studies, we also do animal studies using, for example, rats, where we do optimization and try to understand a little bit more how the system works in the absence of those hormones. So this is how basic research helps clinical research, understanding the mechanisms where those hormones are involved and how the cells function. So.
Brilliant, thank you so much. And I know there's been a mention of hormone therapy already. So I'd like to get a little bit into the recent release of the International Menopause Society's 2024 white paper on menopause hormone therapy, and that we know that there's some benefits. We know there's some controversies around it, guidelines for prescribing, and anything that might be an alternative option for people. So Rachel, I'll come back to you about the white paper and its 5 W's of prescribing.
Yeah.
Who is it for, what it is, when, why, and where it can be accessed. Could you elaborate on that and the significance for your clinical practice?
Yeah, absolutely. So the International Menopause Society released that they would do a white paper every year for World Menopause Awareness Month. And so their white paper recently was to provide a position statement about menopause and menopause hormone therapy, and to address the key controversies around this. And the purpose of it was to provide a blueprint, and it's to base future ethical management of menopause. And it's from a clinician point of view, it's really helpful. And they also have there's leaflets for women that can read as well, so it's more helpful generally. But essentially, in terms of looking at who can take menopause hormone therapy, their definition of this is women with natural and surgical menopause who are experiencing distressing vasomotor, so hot flushes and night sweats, and or vulvovaginal symptoms. essentially it's women who are experiencing symptoms that are distressing. So any of the symptoms you can experience and that are impacting their everyday life, their quality of life. There's discussion within it. So should high risk women be prescribed? And it focuses on categories of women who really should take menopause hormone therapy. So women who have premature ovarian insufficiency, so menopause under the age of 40, and menopause aged 40 to 45, so early menopause. These women should be, if they are able to, should take menopause hormone therapy because they're at higher risk of cardiovascular disease, hypertension, cognitive decline, osteoporosis. So we do strongly encourage these women to take the menopause hormone therapy. So that's who. In terms of what, it's looking at what types and doses. So menopause hormone therapy is, you need estrogen to treat your symptoms. We have symptoms because of fluctuating and falling levels. And the sort of what types and doses is looking at what's suitable for each individual. So it's looking at what you need to think about, what the patient preference is, if they have a uterus, what contraceptive needs they have, what their symptoms are, and the severity of them, and also what comorbidities they have as well. For example, if you have migraines or clots, the dose you need is usually low, but we treat it appropriately. And you need to decide whether women will have it transdermally, so having it through the skin, or having it orally. If you take it orally, there is a small risk of blood clot on the leg and on the chest, and also a small increased risk of stroke. So it's balancing the most appropriate type against their history. So there are different types of estrogen. There are also different types of progesterone, and we're increasingly using body identical hormones, so the same structure as your natural hormones, as it's thought to be lower risk. I'm sure there's lots more information about that. We also use testosterone for treating low libido. So there are looking at what the types of hormones are, when it should be started and stopped. So we should start it if the symptoms are interfering with daily life. And again, with premature ovarian insufficiency and early menopause. It can be difficult, particularly in perimenopause, because the levels are fluctuating, but it's deciding at what point it will be helpful to start it. There shouldn't be a fixed endpoint, and this is a really significant change. You should be on the lowest dose for the shortest duration, but the average length of symptoms can be 8 to 10 years. So it might be quite a long duration, and it will be tailored as you're going along. Why it's important. So there's been lots of concerns about over-medicalisation of menopause recently, but it's important because we need to treat symptoms. And in terms of absolutely linking in with healthy aging, the long-term benefits of HRT. So we know it reduces the risk of cardiovascular disease by half if you start it within 10 years of your last period or under the age of 60, which has a huge benefit. It helps to maintain your bone density, so it reduces the risk of osteoporosis, and indeed can be used to treat osteoporosis as well. So there are other benefits. It reduces the risk of type 2 diabetes, it reduces the risk of bowel cancer. So it's really important to be considering that. You wouldn't give it if you had no symptoms, apart from POI, but it does have huge benefits from taking it. And obviously to balance that, you need to consider the risks as well. And then the where is, where can it be accessed? So it's not universally available. In the UK, we're really lucky. It's very accessible, but it's not worldwide. And we need increased training generally. We need more menopause societies. And it links back to lifestyle being really important, because for women who can't take HRT, or those who don't want to take it, or are unable to access it, it really does increase the emphasis on how important lifestyle is.
Brilliant, thank you. And back to you, Vilma. When it comes to menopause hormone therapy, what are the main areas of controversy or unanswered questions that your research aims to address?
Yeah, since was talked before, there are pros and cons for the menopause hormone therapy. So at this point, we don't know, for example, the time that we should be taking. There's no doubt that it really helps with the symptoms and decrease the risk of osteoporosis development. But there are other side effects that the research try to understand how that happens and try to find alternatives that could be used as a hormone replacement therapy, especially for those people that, for example, have the history of breast cancer and they are not advised to take that therapy. So different approaches like the food that we can take and the exercise and other, for example, other natural compound that can also have an effect like the estrogen, but don't have the side effect of the estrogen. So this is how the basic research is trying to understand and trying to develop new approaches for the hormone replacement therapy. So I don't think if the question that you...
Okay. Thank you so much. And I think we're actually quite low on time in terms of the rest of the conference. So I don't know whether we've got time for questions, but just to wind up a little bit on my end, this has been part of the BIRAX conference, which took place yesterday. BIRAX is the Britain-Israel Research and Academic Exchange Program facilitated by British Council Israel. And I'm part of the British Council staff here in the UK. It was really good to be part of BIRAX yesterday. I'm really pleased to see everyone back this morning, and I'd really like to thank my two speakers for coming along and contributing. This has been really short but beneficial and informative. Thank you so much. And I'm going to hand over to you in the room, Ravid, I think. I don't know if we have any questions.
Thank you, Jen. We have time for one question, maybe. CP?
I wanted to know what is your intake or thoughts about phytoestrogen?
There's a new, there's a type of, so estetrol is a type of estrogen, which is the fetal estrogen, which has started to be used in an oral contraceptive pill. It's an end product, so it doesn't get broken down to anything further. So there's lots of excitement using it in terms of the oral contraception. And as far as I'm aware, I think there is research and plans for it to be developed into using in menopause hormone therapy. It's much more stable and it will give better management of symptoms and it should give less side effects. And what the timeline for that is, I don't know, but certainly it's now being used in oral contraception.
Right. Thank you very much.